narcotic use and abuse in the United States. They defined pain as an unsensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. But they felt that definition in itself needed additional notes so that physicians and patients and the public would know that pain was not just that definition. So their notes include pain is always a personal experience that is influenced to a varying degree by biological, psychological, and social factors. So pain essentially is not universal, it's very individual. And all of those factors affect how somebody experiences pain and how they respond to pain, and that holds true, that it is not a universal, one-size-fits-all type of experience. They also felt that pain and nociception are two different phenomena, and that pain cannot be inferred solely from activity in sensory neurons. So one could experience pain even though physically their peripheral sensory system is not active. And that again comes back to the fact that pain resides in the anterior cingulate cortex in the brain, and that cortex once again cannot differentiate between physical or psychological pain all the time. The pain is also affected through life experiences, and people learn the concept of pain. So pain can be very cultural, and also, since it's a learned experience, it's varied from person to person. So if you've read Paul Brand's book, Dr. Brand's book, The Gift of Pain, you'll realize that cultural expectations of pain and experience of pain varies from person to person based on where they live in the world. So people in India, their expectations and their response are different than those in England versus those in the US. And that's a wonderful book. If you haven't read it, I would encourage you to do so. They also felt that a person's report of an experience of pain should be respected and not discounted. Although pain usually serves as an adaptive role, it may have adverse effects on function, social and psychological well-being. So if you're in chronic pain, your functional, psychological, and social well-being may change, and vice versa. If your overall function or social, psychological well-being isn't well, then that may exacerbate pain. The verbal description of pain is only one of several behaviors to express pain, and the inability to communicate it doesn't negate the fact that it's occurring in a human, that they still may be experiencing pain, but they may not have that ability to communicate it adequately. So you shouldn't just assume that they aren't having pain. The International Association for the Study of Pain also encouraged non-addictive pharmacologic agents to be used, as well, such as NSAIDs, Tylenol, supplements, vitamins, fatty acids, etc., as well as non-pharmacologic treatments such as cognitive behavioral therapy, physical and occupational rehab, interventional approaches such as nerve blocks and electroneuromodulation. They also related that the understanding that a person's report of an experience of pain should be respected, that this will help provide optimal treatment for that patient. And again, pain keeps you alive. It helps you prevent things that could potentially damage your body. However, these systems can go awry and you can end up in the situation of chronic pain. And we always, again, have to remember that emotions, memory, expectations, they all influence the pain a patient feels, and that anterior cingulate cortex doesn't distinguish again between psychologic and bodily injury. So psychic injury could be rejection from a spouse or partner, bullying from a peer, lack of acceptance, whatever occurs can cause psychologic or psychic pain, not just purely body injury. That's why when you have a patient that has completely normal MRI without any structural abnormalities, that patient still could be experiencing pain even though there isn't bodily injury present. And sometimes just expressing that to the patient, your MRI is completely normal, that doesn't mean you're not experiencing any pain, like you've complained about your Achilles or whatever, but it just shows us that structurally you're intact. So let's find out what else, is going on that we can help you with. Sometimes that just reinforces the fact that that patient has been heard by their physician, and then sometimes is a little more relieved and will be more compliant with treatment. Women, especially young women, have a tendency to catastrophize, and catastrophizing is a problem where a person will focus on the worst possible scenario. So no matter what happens, they're convinced in their mind that everything bad is going to happen to them. They're going to have every side effect, every problem, and that ingrown toenail is going to end up in a leg amputation because they're going to get an infection even though they're young and healthy and have no risk factors for that. But that's what they fear. They focus on that worst possible scenario, develop significant fear and anxiety associated with the particular problem, and that all increases the amount of pain that they experience. This can be changed through discussing the expectations of pain, discussing the expectations of a postoperative course, as well as changing some behavioral techniques. Sometimes refocusing the patient, establishing some semblance of normality in their daily pattern can also dampen the errant pain signals. And sometimes some people feel it's cruel. You have to be cruel to be a little kind. And what they have found is that if you continue to refocus a patient on the pain they're experiencing, or how bad is your pain? Is your pain, do you need more pain medication? What can I do for you? Oh, don't move your leg, that might hurt. Oh, how much is that hurting you? Do I need to get you some more ice? That can actually interfere with the person who is experiencing the pain or the sufferer, their efforts to distract themselves. So as we have pain in general, we will have a tendency to try to distract ourselves to keep our mind off of the pain. And in some patients, this does not work very well, or if you refocus in there, they're going to have worse pain. So distraction, providing healthier behaviors, whether that's range of motion with an alternate limb, or the surgical limb, or watching a movie, or participating in some other physical activity. So if they can't walk a lot, maybe they can lift some upper body weights. All those type of healthy behaviors will actually improve a patient's pain level, and these behaviors should be rewarded. Remember, drugs don't stop the pain. They dull the perception of pain, they change our interpretation of it, but basically they dampen the emotional distress that we perceive in our anterior cingulate cortex. So again, those other issues besides the physical ones can all influence a patient's pain level as well as their risk for chronic opioid use and abuse long term. So that's something we have to remember, that those psychosocial factors are sometimes more important than just the physical factors in the patients who do become chronic opioid users and addicted or habitual to the drugs. Screening all adults for illicit drug use. In 2019, the U.S. Preventative Services Task Force came out with a statement, and they felt that all adults 18 or older should be screened for illicit drug use. And because it came out through the task force, the Affordable Care Act required that it was covered free or with a small copayment. So this screening can involve one or more questions involving drug use, frequency, and the risks related to the use. But basically, this refers to your social history. So if you think about your social history and what you're asking patients, you're not only asking them about their use of tobacco, alcohol, caffeine, whether they're employed or not employed, but you can also ask them about use of medical marijuana or illicit drug use, whether that's methamphetamine, cocaine, heroin, uh, things like kratom, which are other drugs that are can be associated with addiction that can be purchased over the counter, as well as their previous social history. What type of household did they grow up in? Are they do they have mental health history? Do their primary relatives have addiction issues? All these questions can be used and could help you identify the patients at risk. The task force, however, did not make a recommendation for people under the age of 18, but the American Academy of Pediatrics has. They recommended screening adolescents from roughly 10 years old through their 20s for substance use such as tobacco and alcohol annually. However, if an adolescent or young adult presents to the emergency department, urgent care, or has the history of tobacco use, depression, anxiety, substance abuse, school, legal, or social problems, or a new onset of behavioral changes, that they should be screened. And they should be screened at every visit with those risk factors if they have had that occur, because it does place them at increased risk. And we think about the risk factors for chronic opioid use, dependence, and abuse. Again, you'll see a lot of the social issues in here. History of childhood adversity, physical abuse, witnessing fights at home between parents or siblings and parents, neglect by a parent or guardian, sexual assault, family history of addiction and first-degree relatives regarding drug or alcohol, pre-existing or personality, mood disorders, depression, anxiety, bipolar disease, schizophrenia, nicotine or alcohol dependence. They're also coming out with additional risk factors that include the male sex, if you're over 50 years old, lower socioeconomic status, if you're Medicaid eligible, or if you fill opioid prescriptions prior to surgeries. These are all additional risk factors that place that patient in that higher category. And the reason why CMS and everybody's so obsessed about it is because when you think about drug poisoning or drug overdose in the United States, the emergency department visits for drug poisoning in the United States between 2008 and 2011 is the leading cause of visits and deaths in the U.S. Now, when you break that down as to percentile of the causative agents, you'll see 24% are caused by methadone, heroin, and opiates, 26% by sedatives, hypnotics, and tranquilizers. So you're essentially looking at 50% of the ER visits and deaths in the U.S. caused by drug poisonings or overdose some of them are prescription drugs, and then subsequently lead to some of that illicit drug use over the counter. And the other 48% are other drug categories. Now, the highest number of drug poisonings or overdose occur in people aged 20 to 34. When we look at the difference between the sexes, they're equivalent. Male and female are the same. And then if you look at persons aged 35 to 49, you'll see it more frequently in women than men. 24.5% of these ER visits result in hospital admission, which is quite costly. And if you look at whether they're self-inflicted or they're unintentional, self-inflicted drug poisonings or overdose occur in women more than men. However, unintentional drug overdose or poisonings occur equivalently between the sexes. So when we look at the CMS guidelines that have come out most recently in November of 2018, because this is the second time that they've come out with additional guidelines, these guidelines are intended to prevent the new cases of opioid use disorder, treat those who are already dependent and addicted, and collect and utilize data to target prevention and treatment in areas of the United States down to the county and community level that have the higher rates of opioid drug addiction and chronic use. So these guidelines are available online, they're easy to access. But basically from these guidelines, you've noticed that they have the prescription drug monitoring programs, and there have been state level policies that have been introduced. These state level policies can limit the number of opioids prescribed. They have once again set up the prescription drug database, and they also require substance training for providers, which is why you're listening to me this evening. When they came out with the original National Vital Statistics System, this system collects information annually. They have noted that between 2017 and 2018, overdose deaths decreased by 13.5%. However, that was due to prescription opioids. The non-prescription opioids involving synthetic opioids out on the street caused the increased rate of deaths by 10%. And the overall death rates increased among Black, Hispanics, and people 65 and older. Fentanyl was the most identified synthetic opioid in this group. When we talk about, again, hospitalizations for people on opioids, we have to include the opioid benzodiazepine co-prescribing that's occurring in our country. National Health Statistics Report in 2020 found that 35% of all the prescriptions written for benzodiazepines had an additional prescription written for opioids at the same office visit. This was when they looked at data provided from primary care physicians. This concurrent use, of course, can lead to fatal overdose due to increased risk of respiratory depression. It also doubled the risk of overdose-related emergency room or inpatient visits. And it was noted to be more prevalent as the patient's age increased, but most frequently in women over the age of 65. So if you have a patient that is on scheduled benzodiazepines, you may consider once again looking at the prescription drug database to see if they have prescriptions for narcotics at home, as well as consideration for providing them a prescription for Narcan to be used in the event of respiratory depression. Additional preoperative testing in patients besides your normal preoperative workup, you may consider once again reviewing that state registry, placing a copy of that. I usually will cut and paste it into my medical record. Sometimes I print off a copy and provide it to the patient if a patient is not very forthcoming or honest with me about their history. And then I will also order labs, hepatitis panel if the patient is over 65 or has history of IV drug abuse, and then also a urine drug screen just to see if that patient is on other medications, if they have a number of the risk factors. There's no reason that cannot be ordered and justified because of that. Regarding patient education, again, one of the CMS guidelines from 2018, you are required to inform a patient of the risks of addiction and the use of opioids. You need to start that conversation about postoperative pain control prior to scheduling surgery. And you need to have the conversation about your limitations as a physician, what you're willing to prescribe and what you're not willing to prescribe. And if there are prescription limitations from a hospital, pharmacy, or insurance policy, you can refer the patient to their particular policy, or you can also print it off and hand it to them. So maybe the policy from CVS or the policy from Walmart, so that they understand that they're not able to get additional medication. So they need to rely on adjunctive therapies, and also realize that no matter how many times they call you, the limits are in place and that they need to respect those limits. Arthritis Research Therapy Source Reference. This was from a study that was published in 2020 where they studied 13,000 hip and knee replacements. And what they found that in those physicians, in patients who had hip and knee replacements, that there were more than a year's worth use of analgesics if the patient had a BMI of greater than 35. So if the BMI was greater than 35, they had an elevated risk for long-term use of analgesics. That included NSAIDs, Tylenol, and opioids after their surgical intervention of their hip and knee replacements. So you can kind of extrapolate that out into podiatric surgery, that some patients over the age of 30, over the BMI of 35 may also have that same type of issue with some podiatric procedures. The CDC has also reported that 20% of patients who are taking opioids 10 days post-operatively will continue to be chronic pain patients and take opioids a year later, and 40% of those on opioids at 30 days post-op will take opioids a year later. A survey done in Outpatient Surgery Magazine in 2019 reported 44% of physicians do not decrease the number of opioids prescribed due to the convenience of fewer postoperative phone calls. So basically, we're not willing to decrease the prescriptions we provide because we don't want the phone calls. So that's why that conversation preoperatively needs to occur, placing the limitations on the patient so that they understand what those limitations are. In reality, how much does this occur? I'm not sure. We get some calls, but they're very few. They're much less than they used to be 10, 15, 20 years ago. Michigan Opioid Prescribing Engagement Network has provided evidence-based guidelines for 25 different surgeries, and they'll continue to come out with more as time goes on. This was a consortium of institutes who studied the prescribing habits, as well as now provided the evidence-based recommendations as to how many opioid pills should be prescribed dependent upon the procedure, and that's available online. If we think about our prescriptions overall, there are 50 million surgeries in the U.S. done annually. 90% of those surgeries have a prescription for opioids post-operatively. And of those 50 million surgeries, 6.5% of the patients become chronic users. When you think about the pills prescribed, there are 1 billion pills that go unused after surgery. And 85% of the pills that are unused come from surgeons and dentists. And we know that 32% of addicts began using drugs because of leftover supplies from someone else. So we as surgeons are responsible for some of the unused pills, which may influence some addicts. So again, if we can cut down on the unused number of pills available, we will cut down on potential addiction. Enhanced recovery after anesthesia. This is something that the Anesthesia Association in the United States has put forth. They recommend the perioperative use of acetaminophen, NSAIDs, gabapentinoids, and corticosteroids. They think overall, and I think as podiatrists we would agree with them, that local anesthetic should occur prior to any incision, that we should be providing adequate pedal and regional blocks with or without ultrasound guidance, whether we're providing the block as podiatrists or we're using anesthesia to provide adjunctive blocks more proximal for a patient. We now have the availability to use liposomal encapsulated bupivacaine, which is a drug branded under the name Exparel. It's the only one out there on the market. It will last 48 to 72 hours, and we know if we can get that patient past that 48-hour mark, they do experience less pain. NSAIDs and acetaminophen, when we look at that, we find that they decrease the release of pro-inflammatory prostaglandins and peripheral pain mediators. We should provide a preoperative dose of an NSAID such as meloxicam or naproxen or Celebrex. Prior to surgery, they are not finding that it increases the risk of intraoperative bleeding much. And we also should consider intraoperative or postoperative acetaminophen use, such as 1,000 milligrams IV. Using NSAIDs and acetaminophen decreased the rate of opioid use by 85% in 85% of the patients. Ketamine is an effective drug agonist of NMDA receptors in the brain. Low doses of ketamine can reverse opioid tolerance. It is recommended in some cases, whether that's opioid tolerance from preoperative use of chronic opioid therapy or intraoperative exposure to opioids, that use of the ketamine in the recovery room can provide immediate pain relief for a patient, although they may experience some delirium, and they recommend 0.2 milligrams per kilogram dose. Alpha-2 agonists, such as dexmedetomidine and clonidine, provide sedation, hypnosis, anxiolysis, and pantolysis, and analgesia. They do reduce postoperative opioid use, but we have to remember that they can cause bradycardia hypotension. So in those patients who are prone to bradycardia or hypotension, this is something that you probably need to avoid. Again, you work with your anesthesiologist in regards to these some of these perioperative medications. Anesthesia Monitor, ASA Monitor, in February 2020 had a nice little table of the suggested perioperative and intraoperative multimodal analgesic doses regarding aspirin, ketamine, methadone, dextromorphan, magnesium, and the alpha-2 agonists and local anesthetics. In those patients who have acute pain, again, you probably, once again, want to limit the number of pills you're providing. In the opioid-naive patients, again, the big box stores are recommending less than 45 milliequivalents per day for a total number of 3 days. So if you're using Percocet 10, that may limit you to 9 pills. If you're using Percocet 5, it may limit you to 18, and some of you get away with 20 pills. Again, oxycodone and hydrocodone. If you think about milligrams equivalency to morphine milliequivalents, 30 milligrams of oxycodone and hydrocodone are equivalent to 45 milliequivalents of morphine. In the chronic pain patients postoperatively, again, you want to increase the dosing by approximately 20% above their baseline. Again, increase that for a total of 3 days and then go back down to their baseline. If you do have a patient who has used opioids extensively, longer than you originally anticipated, you can begin to taper them, no more than 20% prior to the previous day's dose, 20 to 50% per week of the original dose. Don't abandon the patients, and if need be, you can always add a quantity patch for withdrawal symptoms. The consensus of the American Academy of Pain Medication put out a report in 2019 because of the CMS guidelines and how they affected people's prescribing behaviors. They felt that it has been used as an excuse to stop treating pain. The state policies to restrict prescribing and providing insurances limited coverage to control opioid doses could be somewhat detrimental and harmful to patients, and that it should have been interpreted as a regulation. It was interpreted as a regulation, and was used to impose rigid dose and duration limits, which was not the original intention. So there are some additional guidelines available that you can review, and these include educating clinicians about the risks of abruptly discontinuing opioids without focused care. So again, you need to begin a tapering program as well as providing alternative treatments. Not to misinterpret the guideline by insisting opioids be stopped or reduced when they're warranted, and you need to have sufficient reimbursement and coverage for comprehensive pain management services, including psychological and physical treatments, because if they are being tapered off opioids, they need alternative treatments if they do have chronic pain. I think one of the interesting things that we'll see coming out this year and will influence CMS directly, the VA in Minnesota is providing a research study comparing collaborative physician pharmacist healthcare programs versus integrated medical and mental health care team programs that emphasize non-pharmacologic pain management. This is due out in October of 2020 and may provide further guidance as to which treatment model really is better for patients. And CMS may then start to provide additional reimbursement and support for these programs. There's free CDC training available online. You can always go to cdc.gov. They have some great training programs that are free and easy to review. And if you or anybody else you know of has a substance abuse problem, there is a national helpline available that's 24 hours a day. It is 365 days a year. It's free and confidential. And APMA also has support services for physicians who have potential addiction in themselves or their staff or family members. And you can reach me at that email address if you have any concerns. Thanks.
Thanks so much, Dr. Painter, and I'll ask that you join me here on the screen. And while we welcome Dr. Painter for Q&A, I do have a couple of announcements that I'd like to present to you. I do appreciate you staying on till the end with us here today. And the first few announcements we have is we'd like to remind you to make sure you go back into the APMA Online CECH Learning Center to complete your session evaluations. For the first afternoon session, that was the 2 to 4 p.m. on limb salvage, as well as the session that we're finishing right now. There would be 2 separate evaluations. And to check out the sponsor lobby as well as the abstract competitions, you can do that this evening as well. You can find the sponsor lobby and abstract competitions on the main dashboard, the conferences and events dashboard. And be sure, after you've completed your surveys for the 2 afternoon sessions, be sure to put in the attendee verification code, and we will put that slide up here shortly. And we have sent that in the chat bar for those who can see the chat bar. I will read that out later as well as have it on the screen. But Dr. Painter, welcome. We do have a few minutes here for Q&A, and we've got a few questions here lined up for you. So we'll get started. The first question is about gabapentin. Can you comment on gabapentin for pain control related to neuropathy and non-neuropathic pain, back pain, post-op pain, acute injury pain, and how you feel about the risk of abuse now that it's been changed to a narcotic? And you're muted.
Am I unmuted now?
You're good.
Okay, sorry. I think any of the drugs, whether that's a narcotic or a gabapentinoid, can be abused. I think they do have their place in treatment. Again, you need to look at that risk stratification on that patient to determine what their risks are regarding social history, previous history of abuse of different medications. And in some patients, it does make a significant difference in their pain level and their current function. And again, whether it's an opioid or a gabapentinoid, the purpose of the medication is not only to help alleviate pain, but primarily to improve function. So if you aren't really improving function, then maybe it's not best to go down that path. But again, also trying, if you can pinpoint the underlying cause, and sometimes you can also try some other alternative methods of treatment besides just the gabapentinoids. But I do use them. A lot of physicians in our chronic pain management clinic use them as well for musculoskeletal pain. They use them post-back surgery if they still have some radicular pain or hypersensitivity of the nerves after intervention, and they do have their place. But again, with the gabapentinoids, when they are to be stopped, they need to be weaned off and just not stopped cold turkey. And most patients will also get to the point where they can start to wean them after a period of time once you decrease some of that nerve hypersensitivity, wean them down. And in some patients, again, if that medication had been used for a long period of time, Having a drug holiday from a gabapentin can also be beneficial, so you can take them off the drug for a month or two, put them on something else temporarily, and when they go back, sometimes their dosage can be lowered significantly, sometimes even cut in half. But again, the minimal amount of drug required to get the benefit and increase in function that you desire.
Great, thank you. We've got a question here. For patients with memory impairment, such as Alzheimer's or some level of dementia, how is their pain tolerance affected?
Well, that's again one of those things, do we really know? If they can't express how much pain they're feeling, the only clues we have are their physical expressions, their withdrawal effects, or their lack of certain behaviors. So in some patients, if they do have significant dementia or memory impairment, sometimes you'll find that they will stop walking or they will stop whatever activity if it's a pain-inducing activity. So sometimes you have to be very familiar with the patient, follow the clues of the patient, listen to the family. Now, lack of walking in somebody who's been walking around the house 24/7 is different than somebody whose lack of walking when they've been sitting in a wheelchair for a majority of the day and now they just can't get up and pivot and transfer. So you have to always put that into perspective. And again, in some cases, if they are exhibiting pain behaviors with other physical movements, sometimes it'll be rocking, sometimes it'll be withdrawal, sometimes it'll be holding an extremity or protecting it. And it's not just protecting it because they don't want you to touch them, but it's protecting it at other times as well. So you have to pick up on some of those other physical cues. The other thing is even a short trial of, say, an extended release Tylenol in a patient. If it changes their behavior, they're up and walking again, then you can again clue back to there really was something there going on causing them pain.
And Dr. Painter, should all patients on chronic opioids be given a prescription for Narcan?
I don't think all of them should, but there is a list in the CDC guidelines that's provided as to the high-risk patients. So the patients with sleep apnea, COPD, history of respiratory depression in the past, again, other medical comorbidities and medications they're taking, if they're on gabapentinoids, if they're on benzodiazepines, if they have had history of alcoholism in the past. It's never a bad idea to give them the prescription because the worst case scenario is it just goes unused. But it can be provided. I do provide it to some of my postoperative patients if they have significant obstructive sleep apnea or COPD or history even of acute kidney disease, things like that, just so that they have that available in their household if need be. But again, nowadays, a lot of the